Now, this talk is very important because this talk is related to the COVID, and he will tell us. I mean, COVID has changed everybody's life, not only in terms of disease per se, but the way we have been treating the patients, our glaucoma patients also. So, over to you, Dr. Venkatesh. He will be talking about glaucoma management during the COVID-19 pandemic. So, over to you.
I take this opportunity to thank the scientific committee of All India Ophthalmic Conference for giving me this opportunity to talk in this prestigious symposium. So in the next 10 to 12 minutes, I'll be talking about how we were able to do glaucoma care in the COVID era. It's a challenge for every one of us because it's a kind of complex and unique situation. There were a lot of new novel strategies. We had to minimize the spread of infection. We had to protect both our staff and the patients. And also there were a lot of new guidelines which was coming up and changing every few weeks. And normally this is how a flow of patient is. You know, after registration, basic examination, doctors, appointment, optical, medical, in between any additional investigations had to be done. But because of the limitations, especially patients cannot wait long, no, you cannot do several investigations on the same day. You have to avoid crowding, and also there are a lot of health personnel involved. So we had to reduce the number of people involved. So some of the general guidelines, the use of personal protective equipment was so important. We had to use sometimes a single mask or even a double mask or an N95 mask. And this is one thing which every one of us started using, a nice breath shield, which could kind of protect us from the aerosols from patient care who are so close to us. So generally we had to reduce. So we had to kind of schedule the appointments to reduce the patient load. And we did a lot of things to maintain social distancing, like marking where they wait for registration. We even removed the central chair here because when the chairs were there, they used to keep a few things in the chair, which also had to be sanitized. So we just removed the central chair so that there was a social distancing in seating. And also we try to avoid any attenders if they are quite young and healthy. If they needed some procedure surgeries, then we attended one attendant for a patient. In the OPD, basically as minimal time as possible. So we had to do a lot of things around it. And wherever we had to come in contact, we had to sanitize their hands, gloved hands. And the EMR usage was also difficult because gloved hands, the entry was also difficult. So we had to come up with ideas of even something like a resident doctor helping us to enter the EMR information during the peak period. So when it came to IOP measurement, now Goldman tonometer was being used with all safety precautions, and it was kind of sanitized after every use. And then you can see this elegant V-shaped thing, which our team developed with a couple of the Johnson buds, which helps you to keep the eye nicely open to do some procedures like a suture removal or a needling or a massaging and things like that. So this was developed in our innovation lab with a 3D printer, and the buds can be disposed after every use. So the assistant or a nurse need not come and hold the lid, in cases where you want to keep the lids open. And there are several other innovations around care we had to do, especially to prevent fogging. And then we also developed a nice slit lamp shield, which was again published in IJO. And also we had a nice fridge, which was converted into UV chamber for decontamination of the N95 mask and respirators. Non-contact, initially to begin with, there were some controversies on aerosol generated, but there was some very good information and evidence which was coming up showing that there is not much aerosols being generated. So now people use routinely non-contact, and we also use here. And the other way, during the period when there was no clarity, we started using the eye care pin, and then we were safely sanitizing and using it on we tested that up to 8 to 10 patients, the readings are very reliable. Gonioscopy was again restricted to definitive glaucoma patients who had hypertension, suspects, narrow angles, and secondary glaucomas. And we tried to avoid wherever we found the chamber was deep on a slit lamp. And whenever it was used, gonioscopy, we used a basiloid solution to disinfect, and frequent alcohol usage on these lenses can damage the lens, permanently. So it's good to use the sodium hypochlorite solution, and then you keep it for a few minutes so that it gets sanitized before you use on the next patient. Fundus evaluation is another critical step. So you can see this beautiful 90D holder, which again our team developed, so that you don't have to go very close. And also this holder prevents the fogging of the lens. Many of the time, the breath which escapes from the mask would cause fogging of the lens and which can obscure the view. So this holder helped us to nicely hold it, and then the wraparound thing, which was avoiding the fog to fall on the lens. And wherever possible, in suspects and follow-up patients, we did fundus photo and uploaded in the EMR so that we don't have to see the fundus as a routine. The other issue was again Humphrey field testing, and a lot of evidence started coming that there's no significant difference between aerosol count in the bowel of a HFA before and after testing. So after a few months, we started routinely doing HFA. The only thing we did was we taped the mask so that we can reduce the aerosol generation when they are doing the feeds. So again, there's a lot of evidence for it, and taping really helps to reduce it. The other way we were doing fields is using our portable virtual reality-based perimetry, which is called the IVA now. We have tested it, and it is validated to the gold standard HFA, and it's very easy and comfortable to do for the patients. And at the end of the fields, we can also kind of sanitize it using an UV box, which you had for it. And then you can switch out the box and you keep it for a few minutes before you use it on the next patient. And fundus photo, again, you can see there's a nice clean wrap here so that you can clean in between each patient in case if they come in contact with the eyepiece and the surrounding areas. This plastic wrap really helps. Prioritizing is very important. I think most of them, most of the institutes try to prioritize. We already have a very good system called E1, E2. E1 are high risk categories, and E2 are people who need care within a couple of weeks or a month. E1 are something which needs care within a few days. So we have a nice program for it already. We made sure anybody who needs procedures like laser or surgery in an emergency basis, we generated an appointment for them, and we also facilitated them getting an e-pass so that they will not miss the follow-up, and we kept reminding them for care. The surgery was again done depending on the risk and the emergency. High-risk cases were preferred under local anesthesia. All the general guidelines which were followed for cataract was also done. And wherever possible, we were doing procedures like Cyclo G6, which was less invasive, and non-penetrating surgeries were preferred. This is the data just to show what happened during the lockdown period in Aravind Eye Care System. If you see, this is a 5-year data between 2014 to 18, 2019 and 2020 comparing. There was a significant reduction, almost minus 80% of glaucoma surgeries, because people were not able to travel because of travel restrictions. So a lot of planned surgery, especially combined surgeries, cataract and glaucoma together. There was a significant reduction in combined trabeculectomy with cataract surgery. You can see this minus 87%. So there was a huge backlog which we had to clear in the next few months till the second wave set in. So lens-induced glaucoma is just we wanted to see how much change between 2019 and 2020. The volume of number of OP is less, but if you see the percentage is almost double, which you normally is 0.1 became 0.2. So there's a significant increase because of the delay in cataract surgery. A lot of people presented with lens-induced glaucomas. So a day at Aravind, we normally saw 13 to 15,000 outpatients, but following the lockdown, the volume significantly reduced to 1,500 patients during the peak lockdown. And following the unlock, we were seeing close to 3,500 to 4,000 patients across the system. And more importantly, we were able to function because of our primary eye care centers, our vision centers. So the eye examination was after the peak lockdown was happening normally, and many of these patients would go to vision centers where they were having teleconsultation and referred. This is just to show you the different phases of lockdown. So when the unlock process happened, the volume in the base hospital was not significantly increasing. It's only 40 to 50%. But the vision centers and the secondary care centers, which were in the smaller towns and rural areas, their volume went to 80, even up to 90% post unlock during the phases between June, July, August, September of 2020. So the vision centers played a significant role. So this is another thing which we did, where we tried to talk to the patients using a Zoom platform, just for people who had surgery recently, who were not able to follow up. We were just trying to talk to them to see how their condition is, and then we also facilitated if they wanted an appointment to the base hospital. There's always problem with telemedicine, right? When you're doing like this, you need an IOP, you need visual field analysis, you need to visualize the fundus. And that's where we thought, why can't we Uberize eye care? No, why can't we send a vaccinated, trained technician to the home of these patients? So we looked into the data, we fixed appointments with patients who really needed care. And then you can see one of our technicians with all the equipment in his backpack going to the house of one of our glaucoma patients, who needed a kind of urgent care. And then the vision was tested using a peak software. It's a portable eye examination kit which was used, and then the intraocular pressure was measured. Visual fields was done using virtual reality perimetry, and then his fundus photo was also taken using a portable fundus camera, the fundus on phone. And then all these images were Wi-Fi transferred to the base hospital, the ophthalmologist in the base hospital, and he was giving the live consultation immediately to these patients. So we found that we piloted this, and we found that there is a future for Uberizing eye care and maybe glaucoma, diabetic retinopathy care, so that the patients who really need the services, even beyond pandemic, we can do this. And we also explored ideas like this. We have to look at ideas like this, which have been published, where the intraocular pressure was done on a drive-in, and then new digital modes of care was being explored. So we also have to learn from some of these evidences. So again, I would like to take this opportunity to thank, whenever there is a situation like this, we need to be flexible, we need to be agile, and also, again, resilient and open for new ideas to explore. Thank you.